Nadalski Jr. as our speaker on endocrinology, the endocrine diseases of the aging population and the basics. Just as some background, Casey, that's his nickname, I've known Casey since he was a little kid. He went to high school with my kids. Casey went to West Ottawa High School, where he was a scholar. He was also a wrestler. He was a two-time state champion in wrestling and finished twice the other two times. From there, he went to Michigan State University, where he wrestled for the varsity. He was an academic and athletic All Big Ten and academic All-American at Michigan State. From Michigan State, he joined the Navy, was commissioned by his grandfather, who is a retired captain from the U.S. Navy, and by the way, had been on the USS Case during the attack on Pearl Harbor, December 7th, 1941, Captain Birch. In any case, Casey went to Nova Southeast Medical School in Florida, School of Osteopathic Medicine. From there, he re-entered, he was in the Navy. He entered the Portsmouth Naval Medical Center for his training in endocrinology, his residency, and did a postdoc fellowship at Walter Reed. He has since been in private practice with Spectrum in West Michigan, Grand Rapids area, and he's adjunctive faculty for the Michigan State University College of Medicine. So without any further verbiage from me, please welcome Dr. Casey Nadalski.
All right. Well, thank you so much. And it's a pleasure to be here. It's a little bit different lecture than I normally give. It turns out I give a lot of lectures to med students and other physicians. So this might be a little bit more fun and actually maybe a little bit more helpful, because I think giving talks to people who really can help with their own self-management and health can actually do wonders. And so what we'll do today is we'll just talk about what is endocrinology. Well, endocrinology is the study of our hormones, and our hormones are basically chemical messengers in our body that control everything. So really, it's really the most important system of the whole body. Of course, I think all specialists say that about their specific systems. The background of this slide, you can see up here, up in the brain, you have your hypothalamic and pituitary area. That we'll talk a little bit about that. Here in the neck is your thyroid. That makes our heat metabolism higher, the hormone, our thyroid hormone. Down here, I'll go down here to this thing here is the pancreas that makes insulin for sugar uptake in our cells. These little things here, they're probably a little bit bigger on this picture than what they really are. Those are adrenal glands. And then of course, over here on the female are ovaries, and over here on the male are testicles. Those are some of the most common or popular, well-known endocrine glands that we have, and we'll go through there. You notice the heart is here because I'm going to spend a lot of time on obesity and what we call cardiometabolic disease, because heart disease really is one of the biggest issues we have in the world, and it really all goes together with endocrinology in that it has to do with energy balance, obesity, where we hold our fat, and what harm is it causing ultimately with heart disease. And so we'll see about moving on. So some objectives, learn which hormone systems that we as endocrinologists actually evaluate and treat. Appreciate some of the endocrinopathies, we call them, the actual disease process, especially the ones that people have the ability to help prevent or self-manage. And then also, one of the reasons I think John wanted to do this is because endocrinology succumbs to a lot of sort of what we call quackery. There's a lot of goofy stuff out there because people can make money off of it. There's a slide later on where I say hormones are sexy. People, for whatever reason, it can be used by marketing too often for inappropriate things. And so just kind of be aware of some of these red flags, and hopefully that'll also be a little bit fun. So there's my red flags of quackery that we'll talk about. And so sort of as a foundation, when you hear people talk about holistic medicine, really we all of us, scientists, everyone who, and people in healthcare are really technically trained to be holistic. That just means taking care of the whole person, not focusing on one little thing. Or what people will claim is that, you know, doctors just give medicine for something, they cover up what's going on. And I'm not saying everyone's perfect, that by no means, but we all really should be thinking of our patients, and you as patients, or just as a person, think about your health in a very holistic way. But be careful about when you see advertisements that say, oh, we do holistic medicine. Those mainstream doctors don't do that. That's a divisive sort of commentary that is a red flag. Now, it may just be that they're very proud of their ability to be holistic, and that's great. I mean, I think of myself as a very good holistic doctor because I really think about this stuff, but really we all should be doing this. And so, especially for the things we're going to talk about, nutrition, exercise, physical activity, and sleep. These are kind of the unsung heroes of what really holistic health is. So we all need to take care of these and optimize them the best that we can. And none of us are perfect with these, by the way. And so here's some just background red flags to be aware of over here on the left. If you hear of other physicians, especially talking about hormones, since that's what we're talking about, if they're disparaging mainstream medicine, that's a big red flag. If they disparage evidence-based medicine, that's certainly a flag, especially probably to this crowd here. I don't think you guys would be swayed by that. The term balancing hormones. Now, we sometimes will use that term with patients because in some ways it makes sense, but when people start talking about, oh, we got to balance your hormones, that's usually a little bit of a red flag. That's not really a correct term. When they create a false dichotomy, an us versus them sort of thing, that's not true. We're all on the same team. All doctors, scientists, patients, we're really supposed to be all on the same team. And then use caution when they claim to be functional, alternative, or integrative. Those are sort of real potential red flags of quackery. They, unfortunately, the terms can be good, but they're usually used to sort of support this dichotomous sort of nature. So, and they often get into these weird hormone things and try to sell people stuff. So clinical endocrinology, what I do, just a sort of an overview of the different things we take care of. So pituitary disorders, we talked about that little gland behind your eyes that comes out of your brain that makes prolactin, growth hormone. It stimulates our gonadal axis, ovaries and testicles, our adrenal axis that has to do with, in this case, mostly our stress hormone, cortisol, and the thyroid axis, the heat metabolism hormone. And then more specifically, our thyroid, we take care of people with low thyroid, hypo, or too much thyroid, hyper, that can be from nodules. We also evaluate people's nodules for the chance that they could be thyroid cancer. So we take care of people with thyroid cancer. The adrenal glands, they make cortisol. That's our stress hormone. So we have people who don't have enough cortisol, whether it's from the pituitary issue or an actual adrenal issue, or if they have too much. And the most common cause of too much, by the way, when we get to those slides is medication, corticosteroids. When you hear about people taking steroids, it's not usually like muscle building steroids, it's usually this type of steroid. And then aldosterone, I describe as our blood pressure hormone. And then something called pheochromocytomas, or the real catecholamine, the adrenaline producing part of the inside of the adrenal gland. Sometimes those can have rare growths or cancers that make too much of that. And then of course our sex hormones that are relatively well known, testosterone in men, and then for females, going through menopause, and also the most common endocrine disorder in females is something called polycystic ovarian syndrome. Little bit of a misnomer, but really it has to do more with the ovarian part of sort of obesity, insulin resistance, that metabolic syndrome stuff that we'll talk about. And then also that not a lot of people realize that we are sort of the medical bone specialists, to include osteoporosis, vitamin D metabolism, parathyroid, we'll touch on that a little bit, and then just calcium balance and other disorders of calcium. And then my niche is really obesity, diabetes, and lipidology for cardiometabolic health, heart health. So I do want to start with obesity, and I'll try not to make this too long, because God knows I could make this too long. But the basics of it are obesity is you need to understand it as a very complex multifactorial disease that's characterized by excess body fat, generally speaking, and energy imbalance, but also where we hold it. And it's very genetically determined, determined a little bit by nutrition, physical activity, other environmental sources. But we'll talk about a little bit about that distribution later. But it is the underlying driving force for a lot of the disease we have in life these days, that metabolic syndrome, type 2 diabetes. NAFLD stands for non-alcoholic fatty liver disease. It's going to be the leading cause of cirrhosis these days, that polycystic ovarian syndrome, even male hypogonadism, which is low testosterone. In this case, in men who have obesity, maybe sleep apnea, and it just causes that whole system to not work well. Other sort of metabolic states are sleep apnea. That's what obstructive sleep apnea, this OSA, stands for. Osteoarthritis, especially in the knees. Gerd is reflux disease, heartburn, and also stress incontinence, urinary trouble holding your urine. And treatment of obesity really requires a multidisciplinary approach, speaking of holistic medicine before. So the patient, dietitians, maybe psychologists, support structure, all sorts of different ways we can do it on a personal basis to help people, because it's easier said than done. Biology works against people, as we'll get to. And lifestyle is certainly medicine. And you just need to be aware of the complications of obesity and the potential medical therapies that we have. As far as kind of the quackery stuff out there, if it sounds too good to be true, it probably is. But always, discuss this with your doctor or come see me. Here is an overview, and I think I have some cartoons. Yeah, so we don't need to get too much into this, but just so you know, obesity, weight, energy regulation is very complex. You may have heard of this hormone called leptin. This actually comes from our fat cells and communicates with our hypothalamus up here in the brain that really controls our appetite and metabolism. And then we also have other parts of the brain that deal with our cravings and almost that feelings of food addiction. That's our mesolimbic area and everything like that. Catecholamines, so that those adrenaline hormones also act up in the hypothalamus to help with the regulation of food intake. Serotonin, that you might know from like depression medications. Dopamine, not only in the hypothalamus, but also plays a role in those craving situations. Endocannabinoids, so cannabinoids, that's like cannabis, like marijuana type stuff. We have receptors all over our body. There was once an endocannabinoid receptor blocker that worked really well. Unfortunately, it was in Europe for a minute, got taken off the market there because whatever the opposite of high is, it probably wasn't good and actually caused people to not do well mentally. But that plays a role in this whole system. And then over here, if you look to the left where that red box is, these hormones that come from the intestines, especially this GLP that we actually mimic with medications that are really good for type 2 diabetes and weight loss now. And then that goes and helps in the hypothalamus. This hormone over here that you see that comes from the stomach called ghrelin, that's our hunger hormone that makes us hangry. When you get hungry and angry, that happens to me a lot. So we blame that on ghrelin right there. Okay, so just understanding how complex this is. It does ultimately come down to energy in, energy out, calories in, calories out. But the parts of the equation are actually very complicated and based upon genetics and all sorts of things from the food environment. As we know, we're overwhelmed with high processed, high calorie, palatable, yummy food that we can't stop eating, and it overwhelms our body's ability to deal with it. Other environmental triggers, including endocrine disruptors. We're not going to get into that. That's a whole nother topic. And it's hard to deal with actually, but medications, certainly, the microbiome, if you've heard how that's kind of a newer thing that we're learning about, and then certainly physical activity. And so this is just for you guys can look at this later, but all these different contributors, both inside the person and outside the person, that adversely or positively affect our energy balance. And this is really just to show you just so many things that go into this, and we don't have to get into these, but you can see over here, different medical problems, genetic factors, those central appetite regulating systems that we have, the gut microbiome and the thermogenesis, the thyroid stuff, but also medications that people take, even something that nobody can do anything about, like if you were born by C-section. That's associated. We don't, if someone has to have a C-section, they have to have a C-section. There's not much we can do about that. But also maternal factors before a person is born. We have to think about psychological issues like disordered eating for sure. There are plenty of people who have night eating syndrome, by the way. They don't realize it. And until their family says, hey, you know, there are plates in the sink in the morning. And when people are absolutely adamant that they're not eating, and sometimes that happens, we find that a lot. Okay, let's move on. So what happens when somebody does something about this situation? So you change your diet up, you reduce your energy intake, you exercise a little bit more, and you start to lose weight. Well, that whole system then starts to work against us. So the body tries to fight that. That leptin hormone we talked about, that goes down, and there's already some resistance to that hormone. So that works against us. Eating behavior changes. So we tend to have a more preference for the calorie-dense foods like, you know, fatty, sugary stuff like donuts or baked goods and things like that. Our metabolism kind of goes down. It's called metabolic adaptation, maybe a little bit more than it should for our new body weight. So that doesn't help. Some nervous system changes, and ultimately this all tries to drive weight regain. And so that's why this is hard for people. It's easier said than done. And well, how do we do this with lifestyle therapy? Well, we have to individualize meal planning for people the best we can. Look at your diet, see where we can improve upon things, see where we can change get rid of some empty calories. Certainly physical activity. More than weight loss, I really like to talk about exercise as medicine for everyone, for everything we do. And this whole talk will have aspects where exercise helps. But it doesn't necessarily always lead to a lot of weight loss. So the number on the scale isn't what we should worry about too much. It's literally what's on the inside that counts. And physical activity, exercise treats all that stuff, no matter what happens with your weight. Now, just to think about, well, how much weight does somebody need to lose if you have excess weight? And again, it depends on where it is and what the complications are. And a lot of people, let's say you weigh 250 pounds and your BMI says you should weigh like 150. Well, a lot of people think then, well, they have to lose 100 pounds, but that's not necessarily true. So if you look at what our treatment goals are when we have people with obesity and complications of obesity, down here, like the metabolic syndrome, pre-diabetes, type 2 diabetes, we're talking like, you know, 5, 10, 15% weight loss to get really good health benefits for these conditions. And so you don't always need to lose, you know, 30, 40% of your body weight. I mean, that might be good, but really our goals are more about, you know, treating the person's clinical conditions. And so it doesn't always have to be that much. And here's just another list of some things like high blood pressure, the male hypogonadism we talked about. A lot of it really is in this 10 to 15% weight loss. So a lot of times I'll talk about those specific goals for patients. And you shouldn't be disappointed if you don't lose a lot more than that. It's, again, what's on the inside that counts. That's what we have to treat. So now, taking the next jump to diabetes mellitus specifically, which is excess high sugar in our bloodstream, and type 2 diabetes, which is really kind of an obesity-related complication. We'll also talk about type 1 diabetes. But this is basically a pathophysiology with a problem of either uptake or utilization of glucose, which is sugar, in our fat and muscle cells, essentially. And so you have hyperglycemia, or high sugar in your blood. You have sugar in your urine. That's what glucosuria is. That's actually what diabetes mellitus means. It means urinating too much sugar out. Once upon a time, they diagnosed this by tasting it. So I don't advise that, though. And then what we really care about are the complications of that. The microvascular complications. Like, it's the leading cause of eye disease. It's the leading cause of kidney disease. Neuropathy, where you can get numbness in your extremities, or painful neuropathy is really hard to deal with. And then macrovascular, that's like heart attacks and strokes. And so those are the things we really care about, not necessarily, again, sugar numbers per se. It's what harm do they do, and the overall disease process of diabetes. And so traditionally, like I said, type 1, where it's really an autoimmune destruction of the pancreas where they don't have insulin, versus type 2, where it's more of that insulin resistance and leading to a cascade of problems that I'll show you a slide on. And then other more rare disorders, secondary causes. We have people who have pancreatic cancer and they have their pancreas removed. Well, now they have diabetes and we have to give them insulin. And there are some more complicated, what we call phenotypes, like some nuances, and we're learning more. And I think the future holds some potential real precision medicine for some of these different people with these different phenotypes. So here is, I'm going to skip over this. I'm going to go to this one. Okay, so this is just a sort of a pathway of the spectrum of diabetes. So insulin resistance, this would be like more type 2 diabetes, but it can happen with type 1 diabetes. And this is all interacting with our genes, both polygenic, but also some monogenic disorders that cause the pancreas not to work right, inflammation, immune regulation. And ultimately, I'm going to show you a more complex slide, if you care for it, that comes down to the beta cells, which are the cells in our pancreas that ultimately cannot keep up either with the demand just because they don't work anymore, or the demand of insulin resistance. And so this is what we call the egregious 11. These are 11 areas that we know are a component of the ultimate culmination in diabetes, and the diagnosis of which you don't need to worry too much about, but pre-diabetes versus diabetes, those thresholds that we use, I see I paused, so you can't see my hands, but those thresholds that we use for diagnosis really are based upon the risk of the complications, like the microvascular things. So what I want to talk about in type 2 diabetes is really the obesity related aspect. We actually are starting to call this adiposity-based chronic disease, because it's that adipose tissue that we store in our belly, in our liver, and it gets in our muscles, rather than our healthy peripheral fat that is supposed to be working. So those are different areas of insulin resistance. And then what that does is it creates this cascade. We also have problems in our kidney with not urinating out sugar. And we now have these medications that treat that, really good medications for the kidney and the heart. We have issues with glucose absorption in our stomach, immune dysregulation, inflammation, like I said. There's the microbiome, and kind of going back to the appetite metabolism issues up in the brain, increased appetite, the dopamine surge, increased sympathetic tone, all this stuff works against us, ultimately leading to also fat in the pancreas and inflammation, leading into it not making enough insulin to keep up with that demand, and ultimately leading to hyperglycemia. So here's just a little picture of, over here on the left, this is sort of that metabolic health thing. So subcutaneous fat that we have on our hips and legs, while you may not like it, those are actually healthy areas to store our fat. So if those are working, you're probably doing well metabolically. But when they stop working and we start to store it in our belly, in our visceral fat, in our liver, in our muscle cells, and in our pancreas, and it's inflammatory, that's when we ultimately lead to type 2 diabetes. Over here on the right, you can see I added this little part called adiposity-based disease. When we start to get this issue over here on the left in the severity of diabetes over time, this is what happens to these different areas. So in the blue here, you can see insulin production. So here it's working, but then you can see insulin resistance. So the insulin goes up, but then ultimately it can't keep up with it and it goes down, and that's diabetes. Our inflammatory state goes up. You can see in red is the insulin resistance. And of course, with that over time, our average glucose levels go up. And that's what happens with the physiology of type 2 diabetes. This is getting into medications. I don't know that you guys really care about this, but basically we do have several medications in addition to exercise and diet to treat these areas. So again, going back to treating the weight, diet, if we can reduce that adipose tissue that's causing the harm, that's really the underlying driving factor. Exercise can help the muscles, certainly, with glucose. And then we have a variety of medications that actually target all these different areas to help in a holistic manner for type 2 diabetes. So more important for you guys, lifestyle therapy is first line, of course. So nutrition, calorie restriction that we talked about with the weight, getting fat from nuts and seeds and fish and olive oil, that cardiometabolically beneficial type fat that you hear about, rather than saturated fat from butter and fatty meats and trans fats, which is like artificial fat. That's no good. We can use intensive meal replacement shakes to help people lose weight and improve their sugars. Physical activity, again, exercise is medicine for what ails you. Sleep is kind of an unsung hero, very important. And then, of course, we want to help support people with behavioral therapy and really no smoking. So this goes for everybody, right? We can't be smoking. Here for a dietary aspect for obesity and diabetes, this is a Venn diagram I made. So when you hear about all the different diets out there, just know that most of them probably have data to suggest that they have benefit, especially for cutting calories and losing weight. But if you really look at these different extremes, they often have a lot in common. So if you've heard of paleo, you know, eating like our ancestors, mostly vegetables and lean protein and nuts and seeds and berries. Well, that shares a lot actually with plant-based diets who don't eat much animal, and a Mediterranean dietary pattern, which I think we have the most data for cardiometabolic benefits and cardiovascular disease reduction. So more vegetables, lower refined processed carbs, not adding sugars, not drinking sugars, especially, by the way. You know, certainly fish, especially, you know, for the plant-based people, for pescatarians, and eggs for ovo-vegetarians. And you can be low carb, you know, if you have type 2 diabetes and we want to reduce the sugar levels that happen when you eat, you know, you can cut carbs, you can increase veggies, you can have lean proteins, and really you can do all of these things together and individualize it. You can do intermittent fasting where you only eat a little bit one day and then you eat a normal diet the next day, or time restricted feeding where you say, okay, I'm not going to eat from 6 p.m. until 10 a.m. but then you otherwise try to stick to your healthy diet. These are all ways you can personalize your dietary approach for all of these diseases. I'm going to skip through these actually for time, but basically just know that when we are dealing with obesity, cardiometabolic disease, diabetes, we're going to assess your lipids, your cholesterol, your high blood pressure, because it all goes together with your diet, exercise, and medications as needed to achieve those goals to reduce your cardiovascular risk, essentially. And here's just a slide on you guys don't need to get into this too much, but we have a variety of these medications that we consider their benefits for things beyond sugar when we talk to you about them. So some have cardiovascular benefits more than just sugar. So just like we don't want obesity to be a weight-centric disease, we also don't want diabetes and cardiometabolic disease to be a glucose-centric disease. We have to think beyond just blood sugars. We have to think beyond weight and treat the person and reduce your risk for all sorts of other things. Okay, and then type 1 diabetes, historically thought of as young and thin people suddenly requiring insulin immediately, but actually this autoimmune disease can occur later in life and be a little bit slower to cause significant issues. And some people can get away without even needing insulin later on because they've had time to fully develop their pancreas. And then of course, other causes of pancreatic insufficiency, as I talked about, like chronic pancreatitis or recurrent pancreatitis or surgery. MDI stands for multiple daily injections of insulin or insulin pump therapy. That's how we treat these people. You need some sort of basal insulin, just a little bit of insulin all the time, and then you need to be able to cover your meals. So here's just a little graphic of the pancreas and the beta cell making insulin. Here's what it should look like. So you should get a little bit of insulin all the time from your pancreas, and then you need more with meals. And here's what it looks like when you use a needle to give yourself some insulin into your subcutaneous tissue. And down here on the bottom right, these are the different types of insulin we have. We have fast-acting insulins now that are the best for covering meals. And then we have these long 24-hour basal insulins for people that need that. And then some of these other intermediate ones we use for other purposes nowadays, or you know, unfortunately, cost plays a role. Okay, this is a picture of something called a continuous glucose monitor. I literally just put this in today after I saw some patients this morning. This person's not doing so well. So down here on the bottom, you can see this is what this person's blood sugars are running all the time. So the average is around 200, actually 214 if you look right here, and not doing well. We really want most of these numbers to be down between the green, between 70 and 180 most of the time. If you look up here to the right, this is a graph that shows time in range. We want people to be between 70 and 80 over 70% of the time, and we don't want any low sugar. hypoglycemia, low sugar, is very dangerous in the short term, while high sugar is more dangerous like long term. It's actually safer to be high in the short term than it is to be really low. Now I'm going to follow that with, this is an amazing glucose, continuous glucose monitor. This is actually a patient I saw this morning who has type 1 diabetes. She helps control herself with a pretty low, healthy, low carb diet. So she doesn't have a lot of variability to deal with. And she just is immaculate in her self-management. And you can see her time in range is over 90%. If anything, she's kind of hinting on the lower end, but it's really not severe. And she just kind of rides safely right across here with really probably better sugars than what most people who don't even have type 1 diabetes have. It's pretty remarkable. So these continuous glucose monitors are really helpful for people with diabetes. One red flag of quackery I don't think I put in here is, don't necessarily, if you don't have any sugar issues at all, don't fall for the people that are trying to sell you these. It's really not going to help you too much unless you have at least some insulin resistance, pre-diabetes, type 2 diabetes, or type 1 diabetes, to be honest. Okay, so here's some red flags of quackery for all that stuff, for obesity, type 2 diabetes. If people try to convince you that it's all because of carbs and insulin, that's not exactly true at all. If they say type 2 diabetes is caused by carbs and insulin, again, that's not true. There's always a little truth to everything. Carbs, fat, everything like that can cause type 2 diabetes. If people try to say there's only one diet that can work for you, that's not true. Like I said, we can combine all these things and personalize it for you. If they say you can lose weight without creating some sort of energy deficit, that is also false. And if they say, oh, the first step you have to do is ignore all the scientific guidelines, well, that's not true, because again, they're just trying to sell you something, generally speaking. All right, so let's move on. So osteoporosis, like the bone disease that I said we will talk about, essentially a disease of low bone mineral density and microarchitecture that puts you at risk of high fracture. As again, we don't care about your bone density per se, it helps us understand your risk of breaking your bone. Most commonly thought of in postmenopausal females, but it certainly can occur in men, and we have to be aware of that. And we have to be aware of other secondary causes like smoking, also malabsorption and hyperparathyroidism that we'll talk a little bit about. The parathyroid are the glands that control our calcium level. And we have to consider other conditions that cause low bone density and not osteoporosis, like osteomalacia, which is vitamin D deficiency, for example. This thing, TIO, is called tumor-induced osteomalacia. It's a little bit of a rare issue that we won't get into. And think about what you can get your peak bone mass, especially during adolescence, is important. So good diet, exercise, when you're young is really important. So, you know, I think we're all past that point, but good to pass on to our kids. And here's a little picture using a microscope. So here's what normal bone looks like, and here's what osteoporosis bone looks like. You can see why there's an increased risk of fracture. So lifestyle is definitely medicine for bones. So diet and exercise are crucial, not only for bone density, but also for preventing falls and fracture prevention. So as we age, pay attention to balance, strength, make sure you don't have things in your house or where you live that can cause falling, because if you don't fall, you're not going to break a hip, and breaking a hip is a big deal. It's a leading cause of mortality for death. So weight-bearing exercise, very important. It is hard to add bone density after menopause, but again, exercise important for fall prevention. And you can actually progress to pretty heavy weight training that's good for you. And so these are just some guidances on weight-bearing exercise, strengthening, balance, posture. And then let's talk about some of these red flags. So one thing you might hear out there is that, oh, osteoporosis medications are bad and all this stuff. Well, because there are some risks. There's always risks to think about with medications. And so over here on the left, I want to point out that one of the things that you'll hear about is this osteonecrosis of the jaw. And I'll bet you, John, I'll bet you know something about osteonecrosis of the jaw. Now, but for us, for osteoporosis, it's really, really rare. It's more common when these doses of these types of medicines are used for cancer, actually. I don't know if you've seen that, probably, yeah, he's nodding his head. So when you compare these things to other issues, you know, having any type of fragility fracture in adulthood, a hip fracture, or to other things that have nothing to do with this, but anaphylaxis to a penicillin shot, a death by motor vehicle accident, or death by murder. Those are more common than getting osteonecrosis of the jaw for an osteoporosis patient. Not quite as rare as a lightning strike, I guess. And what this 10-year probability shows is that we're really trying to reduce the risk by half with these types of medications, generally speaking. And then you can see here this really little risk of something called atypical femur fracture. And that's where you actually get a fracture because we changed the bone remodeling too much, or actually kind of held it at bay too much. And we like the bones to remodel, where the cells that build the bone work and the cells that break down the bone work. But with osteoporosis, that is, of course, not balanced out. And so these medicines slow that down. And there is, if used for long-term, a little bit of a risk of a fracture in your upper leg area. All right, so speaking of bones and calcium, now we're going to talk about the parathyroid gland that I mentioned. So parathyroid glands are right here, right around, in and around the thyroid. And they, right here is a calcium sensing receptor when you look up close. And they know what our calcium levels are. Calcium levels in our blood need to stay between, I'll just give you numbers without units, but between about 8.5 and 10.5. And it's important for a lot of our electrical activity, our muscle contractions, et cetera. And so it has to keep that very tight. But we want to store most of our calcium in our bones. And then parathyroid hormone can put in or take out calcium from the bones. It can communicate with our kidneys to hold in or pee out calcium. It converts our storage form of vitamin D to the active form of vitamin D, which helps with calcium absorption. And so if you don't get enough calcium, if you don't get enough vitamin D, if you have kidney disease, then you actually can get something called a secondary hyperparathyroidism, because the parathyroid glands are saying, hey, we need more calcium. And so the level goes up, takes it out of our bones where we don't want to take it out of, and keep our calcium levels high. What we see most often in the outpatient setting is someone actually is found to have high calcium levels. Well, whenever that happens, we check the parathyroid hormone, because if it's something else is causing the calcium to be up, like a cancer, or if you're eating Tums all day or something like that, then the parathyroid sensors will say, whoa, all this calcium's in our blood, and they'll go down. What we most often see though is that then the parathyroid hormone is usually elevated. And that means that one of these guys, usually one of them, is working too hard. And so then that brings me to something called a parathyroid adenoma. 80% of the time in that case, we can find a parathyroid adenoma, and the treatment for that is surgery. Now, not everyone necessarily needs surgery, although maybe someday we'll, there was just a study that showed that probably everyone has fracture risk reduction when they have surgery for these conditions. But the major things that we know it helps are when you have really high levels of calcium that cause other problems, when you're young enough that the rest of your life is a high enough risk of getting all these problems, when you have kidney disease that's being harmed by this, and when you have a history of kidney stones, and of course the osteoporosis. So those are conditions that we know treating this will help. All right, now moving on to some other, we'll do this kind of quickly, but this is where I talk about endocrinology is sexy. So there's all sorts of these other ones that are a little bit, maybe a little bit more complicated or not as well known. But there's a lot of interest in hormones out there, as you'll see. Beware of the internet, because it's a place of hotly debated endocrinology, endocrinopathies. And just remember that people who have a little bit of knowledge, that can be somewhat dangerous. Thyroid, adrenal glands, and sex hormones are especially popular, especially with the quackery stuff. So here's again, that pituitary gland. Up in here's the hypothalamus, here's the pituitary gland. It's kind of our master gland that makes a lot of these things. And so here's a quick look. We're going to talk mostly about what's called the anterior pituitary, that makes our thyroid stimulating hormone to go to our thyroid. It makes growth hormone that actually goes to the liver and makes something called insulin-like growth factor 1. That helps us grow, but it's also important for other factors as we age. What I tell patients, I call this the cortisol stimulating hormone. It's called adrenocorticotropic hormone. And then we have these hormones that stimulate our ovaries and the testes. Over here to the right, we actually, from the posterior pituitary, we have something called vasopressin or antidiuretic hormone. If something happens to that, like with surgery or a disease process, that's actually called diabetes insipidus. So diabetes, again, meaning you urinate too much, insipidus has to do because you don't have this hormone, and so you just pee out water all the time. So just for some education, if you ever have a pituitary tumor that needs to be taken out, this is how the neurosurgeons do it. They go up through your nose. It's called transsphenoidal surgery, so they can get up to it without opening up your skull now. So that's kind of cool, and it is a lot safer than full onset brain surgery. Here is a picture of what we call acromegaly. So if you have too much growth hormone from a pituitary tumor in adulthood, you'll start to grow your forehead, your nose, these areas here called nasolabial folds. We ask patients, well, do you have to change your ring size because their hands grow? Do you have to change foot size because their shoes grow? And here's this is a relatively common picture that I see around all the time in lectures. This was a real patient. I want to say maybe Mayo Clinic or something, but you can see this lady, how she changed just over 11 years, and she had acromegaly. And then, of course, if you have this condition before you're done growing, that's called gigantism, like Andre the Giant in some of the pictures you've seen in the Guinness Book of World Records and things like that. All right, so now I'm going to move on to the adrenal gland. So here's a close-up look of those little adrenal glands that we talked about. In here, the medulla, and that's where those catecholamines are made. If there's a tumor of that, that's called the pheochromocytoma. And then the cortex here is where we make most of the other hormones that you're familiar with, the cortisol, the aldosterone, and also something called DHEAS. That's it's kind of a sex hormone. It's actually more important in females for a little bit of like a male androgen hormone. So again, adrenal insufficiency can be primary, meaning the adrenal gland itself doesn't work, or secondary, that means the pituitary system is not working. Cushing's syndrome is too much cortisol. It can be from the pituitary, making too much cortisol stimulating hormone, or from an adrenal adenoma. Too much aldosterone is probably more common than we realize, and you can have a little tumor that you don't even see on either side that makes too much aldosterone, causes high blood pressure, and can be treated with surgery or an aldosterone blocking medication. And then very rare are carcinomas of the adrenal glands. I don't even know if I've seen one of these yet. And so here's just a quick look at again, the pituitary with that ACTH, the cortisol stimulating hormone, goes to the adrenal cortex to make cortisol. We have these enzymes in our body, in our fat tissue. We have an enzyme that converts the inactive cortisol back to cortisol. And in our kidneys, this is very important, we have cortisol that is deactivated into what we call cortisone, so it doesn't overwhelm our kidneys' electrolyte balance. Now, if you've ever heard of people taking licorice or eating real licorice actually blocks this enzyme, and then then the kidneys think there's too much cortisol. It actually kind of acts like that blood pressure hormone aldosterone and causes us to have high blood pressure, fluid retention, and electrolyte abnormalities. So I would probably avoid real licorice, at least excessively, if I were you. This is just how complex the catecholamine synthesis pathway is. I don't expect you guys to memorize this, but if you want to, go for it. You can have these slides later. And then here's just some of the complex adrenal cortex pathways. So you can see we actually use cholesterol under the stimulation of that ACTH, that cortisol stimulating pathway. And then it stimulates this. You can see going down here to make that aldosterone. And here you can see this is the pathway for cortisol. And then here's that DHEA. And then you actually can ultimately make testosterone. That's why it's important in females, because that's where they get a little bit of their androgen. We do have several diseases where some of these enzymes in here are blocked. They're a little bit more rare, but just so you know that those things are out there. Here's a picture of a cartoon of Cushing's syndrome. So too much cortisol, that can be from a pituitary tumor, an adrenal tumor, very rarely to be somewhere else. And these are some of the things to think about. Now, it can be really subtle because a lot of people are struggling with abdominal weight gain. People get stretch marks and things like that. And like I said, when you have too much adipose tissue, you actually have an enzyme that causes you to keep around too much of your cortisol. But when it really seems like a change, and you have some of these changes, facial rounding, redness, hair growth where you don't want it, big purple stretch marks, and loss of your muscle mass in your legs and arms, that's when we start looking for this. And here's just a picture of like an adrenal nodule, how that can look in cartoon version. All right, so red flags of quackery. Mostly adrenal fatigue is what you're going to hear out there. This is like for whatever reason, this became famous because people struggle with fatigue. Fatigue is like the ultimate holistic thing that needs to be evaluated for. So many things cause fatigue. Fatigue is real. Adrenal fatigue is not. If you have an adrenal problem, that's a big deal. So if you hear people talking about adrenal fatigue, I would run to some degree, even if they may not know they're causing problems. But we can have axis dysfunction from our pituitary to our adrenal glands that can be treated with lifestyle therapy. So that's fine. But if people are going to start selling you supplements or medications, really, really avoid that. And make sure that you're being evaluated for other causes of fatigues, because I hate for people to miss that when they just think it's the naturopath says it's adrenal fatigue for no good reason. If you go online and Google adrenal fatigue, beware. This is what you're going to find. There's a lot of it out there on the internet. All right, thyroid. So quickly, we talk about low thyroid hormone, hyperthyroid hormone. Here's the hypothalamus up here, the pituitary. Pituitary makes thyroid stimulating hormone, tells the thyroid to make mostly T4, makes a little bit of T3, which is what actually does the heat metabolism in the nuclei of our cells. And T4 in the body can be turned into T3 as needed. And so sometimes people with hypothyroidism that have a problem with their thyroid, the most common cause is called Hashimoto's. It's an autoimmune disease. Some people might not make enough T3. So you'll hear some of the things out there, oh, everyone needs to check their T3 and all this stuff. Well, there's a little bit of truth to that. So just be aware. And then this whole thing works in a negative feedback loop. And so the TSH actually is really, really good at telling us if the thyroid is working, as long as the brain is working. So primary disease can come from autoimmune disease, mostly Hashimoto's. Certainly if surgery causes hypothyroidism. In other parts of the world, iodine deficiency has historically been a major cause. And then secondary hypothyroidism, much more rare, but if something happened to the hypothalamus or pituitary, which happens with some of our pituitary patients who had surgery. And then there's something called sick euthyroid syndrome. So once in a while, somebody accidentally checks thyroid hormones when people are critically ill in the hospital. If we check this in the people we have with COVID in the hospital, we're going to find just kind of everything is sort of low. That's the system just kind of shuts down. It's called sick euthyroid. You can kind of do that to yourself if you're under a high amount of stress, you're not eating much, maybe you're over exercising too much. So you can kind of do that to yourself. Hyperthyroidism can also be from an autoimmune disease where the antibodies stimulate these receptors, these TSH receptors. It's called Graves' disease. And that makes too much thyroid hormone. Heart racing, heat intolerance, tremors, inappropriate weight loss, and can be very, very dangerous. You can also get it from nodules that are just functioning too much, or commonly just taking too much thyroid hormone, which, by the way, can be in supplements amazingly. And I think that's supposed to be illegal, but people sell like cow and pig glands. So don't take other animal glands in supplements, by the way. That's a red flag of quackery for sure. So when you hear other people say, well, TSH is no good, you got to check the whole thyroid panel. Little bit of truth to some of that, but not really. TSH is actually the best marker we have. Don't ever let anybody try to sell you on checking something called a reverse T3. That's a huge red flag of quackery. That would be something we might use in the hospital if we really, really, really don't know, or an extremely rare condition called consumptive hypothyroidism. But that's, you should never need to worry about that. And when they make claims like, oh, mainstream medicine, they don't evaluate or treat the root causes, that's a red flag of quackery. Not everyone is great at it, and that's true, but we all are trained, that's what we all should be doing. We should be looking for the root causes anyways. So here's just a picture of our sex hormones. Over here on the left, here again, here's the pituitary making the LH and FSH that go down to our testes or ovaries. Back to the adipose tissue, it does play a role. So that leptin hormone, again, that goes up to this area. This arcuate nucleus is actually where we have that appetite metabolism center I talked about. And that plays a role with our whole sex hormone pattern. Over here on the right is kind of maybe the females recognize this. This is how our menstrual cycle looks. So here's the pituitary hormones with ovulation. And here are the actual estrogen and progesterone hormones. And here's actually the uterine lining right here. And so male hypogonadism, low T. And so you'll see people trying to sell you on testosterone replacement therapy. It can be primary or secondary. So the testicles can fail, or the pituitary hypothalamus can fail. The symptoms of this are, decreased vigor, really specifically more low libido. So if you're a guy, normal function is to think about sexual stuff once in a while. You should have thoughts and desires. That's a normal thing. If you suddenly don't have that, and that seems bizarre to you, that's a concern. Okay. What we see most commonly, to be honest, is not like pituitary disease or testicular disease, but we see obesity-associated hypogonadism. And I don't know how many cartoons I have in this, but that central obesity we talked about, the cortisol we talked about. Remember that enzyme that causes too much cortisol to be around, that causes problems. Sleep apnea causes problems. We have the enzymes that increase the estradiol, the female hormone from our testosterone in adipose tissue. The high inflammatory state, ultimately leading to lower what we call hypothalamic pituitary testicular axis and low testosterone. I'm going to go through this. The treatment for obesity-associated hypogonadism is treating the obesity, really. What all these things say, this was from a slide for doctors. You guys don't have to worry about it. But really, diet, exercise, treating your sleep apnea can really treat this if that's the actual problem. Yeah, I'm going to fly through these because I don't want to waste our time. So I would have significant caution with places that claim to be men's health clinics. Now, they may be totally legit and they just focus on men, but I would have some healthy skepticism. If it seems like they're selling TRT to everyone, really, they might just be basically selling anabolic steroids quasi-illegally, which I can't stand. If you actually have these symptoms, a real physician, real endocrinologist will make sure that you don't have a hypothalamic pituitary or testicular issue. And if there's something that can be fixed, like obesity or other medications, then maybe those can be taken care of. And maybe you do need testosterone replacement therapy, but just use caution and have a little bit of skepticism. So female reproductive health, again, this is the basic menstrual cycle. We'll fly through this a little bit. PCOS, that metabolic reproductive syndrome, really has to do mostly with insulin resistance, we think, and it just causes dysfunction to the ovarian system, and females end up with too much testosterone compared to what they should have. And so they make too much androgen, and then it kind of screws up that whole axis. Maybe going back to this is where kind of the hormone balance is actually a reasonable term to use. The hormones are not balanced in this case. Okay, try to get through this. I didn't realize I had so many cartoons in this, obviously more for some other people. So I would beware of those who try to sell compounded hormones. Now, sometimes those are okay, but compounding pharmacies are not very reliable, and they can have some dangerous stuff in them. If you hear a term called estrogen dominance, I would consider that a red flag of quackery. That's not a real thing. But otherwise, if you go through menopause and you have hot flashes and they're bothersome, you should discuss that with your physician. If you know young adult females who have irregular menstrual cycles, things, they have too much hair where they don't want it, acne, they should be discussing that with their physician. And exercise is medicine for both things, for PCOS and for going through menopause. That can help with some of the hot flashes, and it's very important for the bone health after menopause, because again, that's one of the most important things. So try to conclude, so we have a little bit of time to talk. Endocrinology is a fundamental aspect to health. Beware of some of the quackery, and really any questions. I do have to get to another meeting in like 6 minutes, but maybe there's some questions I can answer.
Casey, I have one for you.
All right.
Hi, everybody. I don't have anything that's been typed into the chat. So if you'd like to unmute yourself to ask a question of Dr. Nadalski before he has to go, feel free to do that.
All right, I'll go first. Casey, would you comment on the role of inflammation, particularly in more of a macro level, of activating excessive levels of C-reactive protein?
Yeah, so in that case, so that really gets back to some of the cardiometabolic stuff, kind of that overlap between cardiology and endocrinology that I actually personally like. So Now, CRP can be a marker of high inflammation. So that's more like rheumatology. So things like rheumatologic disorders, very high inflammation can cause an elevation in that. And that can be a marker for them to start looking for other things. But we can use something called high sensitivity CRP when maybe we don't quite know if we want to use medication to lower cardiovascular risk, like statins for cholesterol. And so that's one of those things we can add on, because if it's elevated, that's a marker of sort of maybe a subclinical inflammation that probably is due to sort of that adiposity-based disease I talked about, the obesity. That's kind of, maybe we don't have the metabolic syndrome criteria and these things that are obvious yet, but it's a marker of it. And that could push us over into treating it, because we know that those people have reduced cardiovascular events in that case.
We do have a request, Doctor, for if you can share your slides or part of them. So if you would want to email those to John or to myself, oh, sure. I could share those with the registration.
Yeah,
people.
Absolutely.
Okay. Anybody else?
Yes, I have a question for Dr. Nadalski.
Sure.
Is there any interplay with high potassium levels connected with I think you called it aldosteronism?
Yes, yes, absolutely. Yes. So that blood pressure hormone aldosterone, too much of it. So when we have like one of those little tumors or some other rare disorders that cause too much, or eating too much real licorice that makes the kidneys think the cortisol is aldosterone, what it does is it causes our kidneys to release potassium. So it actually can lead to low potassium in our blood when you have too much aldosterone. Now, if you have too little aldosterone, like with adrenal insufficiency, if our adrenal glands don't work, or some other variety, some kidney issues can lead to that, then you can end up with too high of potassium. And yeah, that's dangerous for some of our electrical conductivity, especially with our heart.
Great, thank you. Anybody else?
I think I see Richard talking.
Oh, Richard, you're muted. Richard, Dr. Swanson, you are muted. There you go.
Okay. Carl, who was the chief of medicine when you were there at Portsmouth?
The chief of medicine? Well, of internal medicine, chief of medicine, I mean, Jeff Cole was, do you know Jeff Cole?
No, Jim Lee was there when I was there.
Oh,
Who was the head of endocrinology?
At Portsmouth?
Yes.
See, it was a relatively small department. Was it? I'm trying to think of who actually would have been the chief around that. We switch around all the time so much in the military. Who did you know back then?
Jim Lee was the chief of medicine. Andy Guy was the chief of endocrinology when I was there.
Okay. I know those names. I don't think I know them though. That they sound familiar.
Okay. Well, I was just curious. I went there. I did my residency there too.
Oh, cool. Oh, very good. Yeah, we had a great residency. Really good. As good as it gets. Very appreciative of that residency program.
Thanks very much.
Yeah, thank you.
I don't know if you have time. I have one last question regarding, are the effects of obesity reversible?
Yes. I would like to say yes. Now, it doesn't mean you can, I would like to say we can put a lot of those complications of obesity into remission. Again, easier said than done.
Right.
We think of it as a chronic relapsing disease because that physiology is always working against you, and things like the complications like type 2 diabetes is always a concern, but we can put type 2 diabetes into remission, and we try to do that.
Okay.
Easier said than done.
Just a comment that it seems to be difficult to find doctors in the field of endocrinology, and the question is whether or not there's anything they're trying to do to recruit more.
We're struggling a little bit. I hate to say it, but part of it is You know, we're not proceduralists, we're not surgeons, so it's not like it's the highest. In fact, it's not at all. It's one of the worst paying physician jobs. So it's, you know, we need to recruit people because they want to do it, and we need to do better in healthcare in general to make our jobs not easier, but better for us and patients. Yeah, I mean, you guys probably all know the way healthcare is just not really the right way to do it. And we have to find a way as a planet and a nation and our local systems to do better. So I have ideas of, you know, about, you know, guiding primary care and spreading our net wider for those few of us. So, yeah.
Okay, great. Then the last thing, I know you have to go, so maybe you could include this with your email to us, is just
Sure.
if you have any recommendations for best drugs available today for treating osteoporosis.
Yeah, I'll shoot you some stuff.
Okay.
That gets a little complicated.
Oh, okay. John, do you
Yeah.
want to wrap us up?
Well, I think it was a great talk. Thank you, Casey.
Thank you.
You just did a wonderful job. I know Richard, I can see his face there. He enjoyed it too. We
Thank
love
you.
anything about wives' tales and quackery.
Yeah. Well, thanks, guys. I appreciate it.
So thank you. You did a great job.
Thank you so much.
I'll see you around.
All right. See ya. Bye-bye.
Thank you. Thanks everyone for joining us on this Friday afternoon. Have a great weekend.
Yeah.
Hey.